Thanks very much, Harry. And thank you very much to the U3A for having me. Okay, population health history. How did the southwest of England fare in the second half of the 19th century? And as Harry said, I'm going to be talking about work I did during my PhD. I'm also going to be talking about work I did with the late Professor Bob Woods at the University of Liverpool when I worked as a research assistant on a couple of projects that led to an atlas of Victorian mortality and a book on the demography of England and Wales. Okay, I'm part of the Addressing Health team, as Harry's mentioned, which is led by Professor David Green. And then there's Dr. Doug Brown, who I think is in the audience, Dr. Kathleen McElvenna, Dr. Laura Newman, who's, as Harry said, is taking some well-earned leave, Harry, and two PhD students, Natasha Prager and Holly Marley. And thanks everyone for coming. Okay, so I'm going to talk about three things in connection with population health history. I'm going to talk about healthy districts. How do we classify environments as healthy or unhealthy? I'm going to talk about the urban penalty. So this is living in cities and towns and why that's bad for your health. And I'm also going to introduce a concept that I developed in my PhD, the industrial penalty. Why there might be areas that might otherwise be broadly rural, but might have an industrial environment. And in the case of the Southwest, I'm going to talk about tin mining in Cornwall, that might be deleterious for health, and much more so than just living in otherwise rural environment would be. So starting in present day, this is a map which we're all too unfortunately unfamiliar with. This is COVID-19 cases up to the 1st of October 2020. This is the 7-day rolling rate. And what you can see is that Plymouth and Exeter, being cities, have the highest rates. Though throughout the pandemic, the Southwest has had lower rates than the rest of the country, and has a death rate less than half of the highest region, which is the northwest of England. So it's strikingly healthy. Has the Southwest had an advantage previously in the past as well as today? So I'm going to focus on Devon and Cornwall because they're the areas I studied in my PhD, but some of the maps are national and you'll be able to compare the Southwest to the rest of the country. Essentially, low population density reduces risk of transmission of infectious diseases. This was clearly very important in the 19th century, and it's become important again with COVID. But were there inequalities in this? As we can see here, there's rural-urban differences. Were there any others? So, disease environments. William Farr, who was Registrar General, coined the term healthy districts, and many of these were in Devon and Cornwall in the late 19th century. And then the late Bob Woods further classified districts of England and Wales, focusing on 4 domains. So that's crowding, air, water, and phthisis, or respiratory tuberculosis. And based on mortality from those diseases and the age groups that were most associated with them. So he looked at 2 periods, 1861 to 70 and 1891 to 1900. So for crowding, the measure most associated with that was measles early childhood mortality. So that's deaths in the ages 1 to 4. For air, he focused on respiratory diseases and diseases of the lung. Classifications were slightly different in the 1860s and became a bit more sophisticated by the 1890s. And that was looking at respiratory diseases in older age groups, so age 65 to 74. For water, he used diarrhea and dysentery infant mortality rates. That's mortality in the first year of life for both periods. And then for phthisis, respiratory tuberculosis mortality, it's age groups 20 to 24 and 25 to 34 for both periods. So anywhere that's shaded white, and there's quite a lot of Devon, Cornwall and the wider southwest that is shaded white, had life expectancies of birth in this period of over 48 years. Now, that may not sound particularly high. The lowest life expectancy in the world today is in parts of Africa and is around that level. But at the time, that was high. What's important to note is that high life expectancy doesn't indicate death around the age of 50. It indicates generally high levels of mortality in infancy and childhood, which drive life expectancy down. The three towns of Plymouth down here, and then Exeter and the surrounding areas had of St Thomas around Exeter were all in group 2. Group 2 in black, life expectancies of birth under 48 years. And that's similar to other cities, Liverpool, Manchester, those sort of locations. Unsurprisingly, high population density leading to high infectious disease mortality spread. The majority of the rest of the districts in Devon and Cornwall would fall into the healthiest area were it not for having higher risk in one of the 4 domains. So those areas are shaded with diagonal lines. 3 areas, so the hinterland around Plymouth and in Tavistock and Penzance, and you start to get a sense that it's not just urban areas, but it's suburban areas as well, with higher levels of population density. They scored badly in 3 domains, and a couple of districts, Helston, St Germans and Newton Abbot, scored badly in 2. This mixed pattern in Devon and Cornwall is unlike that of other large rural areas. If you look at Wales and you look at Norfolk and East Anglia generally, you've only got them scoring badly in 1 domain, and that's respiratory tuberculosis. So Devon and Cornwall, and generally the wider southwest to some extent, is actually got quite a much more varied pattern. So what might explain that? So when I was producing colour maps for the Atlas of Victorian Mortality, which back in the mid-1990s, that was actually quite new technology. We see brightly coloured maps on the news most days now, but brightly coloured maps, when I first presented them at an international conference, actually led to oohs and ahs back in 1995. But everybody would look at them and go, oh, you know, that's good. You know, light colours are high life expectancy. That's not surprising. Lots of Devon and parts of Cornwall with high life expectancy. And then they'd look at the tip of Cornwall and go, what's happening down there? Why is the southwest, that tip of the southwest, so much worse than the rest of those rural areas? So this is life expectancy at birth in 1861 to 63. And what you've got is parts of Cornwall having similar life expectancies to the towns that form the city, eventually form the city of Plymouth. And so you've got Penzance, Helston, Redruth, Truro, Falmouth and St Austell not in the top group where you the best group where you might expect to find them. So what you'd expect, really, if this was the case, is that something in childhood would be driving life expectancy down. So what we've got here is infant mortality, and it goes clockwise. You start top left over time, you go along the top, then you go down to the bottom right, and then you go across in time. So it's a clockwise map. And what it allows you to do, it allows you to show the difference between 1851 here and 1901 to 1910 below it quite markedly. And as you can see, much of England and Wales improves in this period, including Devon and Cornwall. So the parts of Devon and Cornwall that had infant mortality rates above 100 in the mid-19th century, by the early part of the 20th century, a lot of those dropped to below 100. But still there remains in the southwest tip of Cornwall some sort of disadvantage. I did similar maps for early childhood mortality. They didn't show the same effect. So which kind of makes sense. Early childhood mortality is driven by infectious disease mortality and overcrowding, in particular measles. But something's happening here with infants. It's very tempting to think that this is due to diarrheal diseases, because the relationship between diarrheal disease and population density is not linear. So this is from the Atlas of Victorian Mortality. This is infant mortality rate in red and the diarrheal and dysentery infant mortality rate in blue, mapped against the log scale of population density persons per square kilometre in 1861. And as you can see, there is a sort of linear relationship with population density and infant mortality at the lower levels of population density. But once you get to a certain population density, it becomes a lot more fuzzy. The line sort of disappears. And you don't necessarily increase your infant mortality in an area as its population density increases, and perversely, you can also get very high levels of infant mortality in areas where population is not that dense. And this is Devon and Cornwall on its own. So I plotted the infant mortality rate, which is the white squares, and the early childhood mortality rate, which is the black diamonds. And there's definitely an effect where on the right-hand side of the graph, the towns of Plymouth have the highest levels. But particularly for infants, the graph isn't as straightforward, with a certain set of areas, which are these areas on the map that stand out, having really high levels of infant mortality of sort of around 180 per thousand, whilst still having relatively low levels of population density. So something is happening in these districts that's putting infants particularly at risk. So how are the tin miners themselves doing? This is William Farr was also interested in occupational mortality as regional districts. William Farr is essentially my sort of academic scientific hero, because he's interested in all the kind of things I'm interested in. So Naomi Williams, who I worked with in Liverpool, produced this data, and it standardized mortality rates per 1,000 population for a set of periods from 1861, 1871 through to 1910 to 1912. And on the left, you've got mortality among all males. And what happens over the period is that after a brief rise in 1890 to 92, which coincides with other infectious disease pandemics in older ages, possibly a late sort of Russian flu, which may have even been a coronavirus. But other than that little peak there, mortality goes down over the periods for adult men, and it goes down for adult men in work. And what you've got in the middle of the graph is the geography of coal mining. So right through from Durham and Northumberland in the northeast, through to Monmouthshire and South Wales in the west of England and Wales. You've got ironstone miners. They're also experiencing a decline in mortality over this period. And then stuck on the end are the poor old tin miners. They start off worse, it continues to get worse, and it doesn't improve very much over the period. So it's not just infants that are suffering in this period, it's tin miners as well. Just go back to that one. The majority of deaths were from consumption and respiratory mortality, and this was noted in the Mining Accidents Journal. There was also poor sanitary conditions in the mining districts, and these were noted by a local government report from Redruth in 1877. There was also technological change in the period, which was detrimental to the health of miners. So a new machine drill was introduced, and the amount of dust that produced increased, which obviously was harmful for health. The attempt that the industry brought in to improve the health of the miners was not what was done in France, which was to provide showers. Instead, they provided water jets to wash the dust off the mine, and that actually led to the dust and the water getting spread onto the miners. The miners didn't like this. Obviously, they were getting wet. It made it incredibly humid, so they turned these water jets off. And therefore, the industry could blame the miners for their own poor health. In the later period, so in the early part of the 20th century, in a paper discussed by Proctor in 1999, there was also a focus on poor hygiene. And again, the miners were being blamed. Yet comparatively, compared to what was happening in other parts of the world, where showers and bathing was being introduced, the miners were actually being unfairly treated. Unlike tin miners, women in Devon and Cornwall had higher than the national level of life expectancy. So what was it with the father's low life expectancy? Was that creating a financial penalty for the infants, or perhaps there was something about the diseases or wider environment that miners occupied that was also affecting infants? So to answer these questions, I spent time in archives in Exeter, Barnstaple, Truro and Redruth, trying to unlock an explanation. I used medical officer of health reports, and that's what we're using in our addressing health project, but I used the local ones rather than ones for a particular industry. And I also had a journal from a medical officer of health where he essentially wrote down what he saw, which was fascinating. The records were patchy and varied between places, and to some extent those records actually almost reflect the interest that the local area was taking in its population's health. So I looked at the Honiton urban and rural sanitary districts, and they had a largely complete set of handwritten reports from 1877 to 1914. I looked at the 3 towns of Plymouth, and they had printed reports from the 1890s. And there were some brief reports from East Stonehouse, but not as extensive as Devonport and Plymouth themselves. And to capture an industrial mining area, I had the journal of the local medical officer of health from Phillack, which is near Hale in Cornwall. So what actually could the medical officer of health have done? In rural areas, they were part-time. They earned around about 10% of full-time medical officer of health wages if you compare Honiton with Exeter. What they did do was promote breastfeeding, discourage artificial feeding and supplementation, and protect the wider milk supply and food supply. They were involved along with inspectors of nuisances, which is one of my favourite occupations, though it must have been a pretty horrible job, in ensuring clearance of cesspits, rubbish removal, street cleaning, disinfection of buildings and clothes, isolation, vaccination against smallpox, and reductions in overcrowding. So on the subject of breastfeeding and artificial alternatives, the Honiton Medical Officer of Health was rather didactic. That was quite common in this period. So he writes, "I know from experience that great ignorance prevails among the poor on the matter which is supported by the temptation of cheap products largely advertised as useful and good food. I'm forever preaching," and he actually uses the word himself, "I'm forever preaching in the district in which I practice that corn flour prepared in the usual way with warm water only is about as useful as diet as paving stones and nearly as dangerous." He did actually praise mothers when infant mortality went down. So he did seem to see a link between their behaviour and infant health. One of the Stonehouse Medical Officers of Health noted link between the milk supply and infant well-being. In Devonport, blame was also laid at the mother's feet, but the Medical Officer of Health noted the link between hot weather and excess mortality at the turn of the century. Essentially, some very hot weather at the turn of the century led to infant mortality rises. And these infant mortality rises were described by Williams and Mooney, so Naomi Williams and Graham Mooney, as the sanitary test. And lots of places in England and Wales failed this sanitary test. Yes, they had water supply and sanitation, but it wasn't really up to the job when the weather got too hot. In the Plymouth district, the focus was mainly on the safety of food supply. There's quite a lot talked about to do with kind of things like fish supplies and things like that. But he also writes about milk. To call this stuff condensed milk is unquestionably misleading to the public, and doubtless the health of infants fed on it is prejudiced by the absence of one of the most necessary and nutritious constituents of milk. The absence of any kind of regulations to control its sale is much to be regretted. And he's talking about fat, and that's really important for infant milk. And now we do have legislation that prevents the sale of artificial milk being advertised until children are at least 6 months old. So if you see artificial milk adverts on the television, they'll sort of discuss how they're not suitable replacements for breast milk, and they're very much got to be targeted as follow-on milks rather than milks from birth. Conversely, in Redruth, where infant mortality was high, the milk supply, breastfeeding didn't feature at all, either in the 1877 report nor in the Philax Medical Officer of Health's notes. Regarding the water supply, in Honiton, it had piped water from 1880, but there was still an outbreak of cholera related to a well, and the last public and private wells were closed in 1899. Honiton also failed the sanitary test at the turn of the century because it did have an infant mortality peak then. So even though these places had water supplies, they weren't that reliable. The Plymouth Medical Officer of Health also highlighted the vagaries of the piped water supplies. But at least they had something. And in 1877, there was almost no sewerage or drainage in Redruth, and little interest from the Sanitary Committee to address this. Unlike in nearby Hale, which was part of the Penzance registration district, which had a piped supply supplemented by standpipes. By 1893 in Philax, when there was a leaking cesspit, rather than repair it, the local government board just closed it down. Following an outbreak of typhoid in 1894, the Sanitary Committee merely removed the pump handle. So they're not introducing a water supply. There was further deepening of a local well against the Medical Officer of Health advice. It must have been a fairly desperate job being the Medical Officer of Health there, because they didn't listen to anything he did. He reported similar events throughout the year, and he wrote, "There was a long discussion on the water question, nothing whatever done." So moving on to overcrowding. In Honiton, there was very little focus on overcrowding, unsurprisingly, with population density of 4.6 persons per house. In Plymouth, there were 8.5 persons per house, which was higher than Liverpool even at 6 persons. Again, there's some blame apportioned to the people themselves, to descriptions of slum makers slum dwellers being the result of slum makers, but there was also discussion about unaffordable rents there and in Devonport. Housing in Redruth was problematic. Though there were stone cottages, there were also some cob cottages with bare earth floors, and 8 to 10 people were reported to be sharing a bedroom. The 1877 report made a link between this overcrowding and infant mortality. So one synergistic effect of a poor water supply and overcrowding that might have explained the pattern of infant mortality and minor mortality was arsenic poisoning, and generally wider respiratory illness. Whether this was directly in the water supply or through contaminated dust on the miners' clothes, or some combination of both, it would tie in with the pattern of excess mortality from respiratory diseases. So to investigate this further, I did detailed examination of data from the Philax Medical Officer of Health journal. It must be noted that these are small numbers, so merely indicative and not conclusive. So this first graph shows deaths in under ones, ages 1 to 4 and under 5s combined in FILAC for selected years and their seasonality. And if there was increased rates from infant mortality due to diarrheal diseases, as there had been in Plymouth and Honiton, we would expect peaks in July, August and September. And they're simply not there. They appear in the winter, October, November, and again in the late spring in April. And then finally, this is other causes. So this is the deaths that haven't been ascribed a cause. And again, the peak is in November and in this case in January as well. And this suggests that it's consistent with respiratory diseases. So to summarise, Devon and to a lesser extent Cornwall were largely healthy in the late 19th century. Urban areas had very high mortality and low life expectancy associated with overcrowding and poor water supply. There was an industrial penalty experienced by workers and infants in the mining districts of Redruth. There were similar problems with domestic overcrowding and poor water supply as urban areas, but lower population density than the cities and large towns meant young children were not as much at risk as infants. Arsenic poisoning in the mining dust and through the water supply in Cornwall, combined with lack of domestic washing facilities in the cob cottages, may have put mine workers and infants at heightened risk. And I'm going to show you a screenshot from an article from the BBC from 2016. Toxic arsenic found in Cornwall private water supplies. It's still possible to experience arsenic poisoning in Cornwall if your water isn't from the main supply. Thank you.